Health and Social Medicine. And as our beloved friend and colleague and teacher, Paul Farmer, began his own reflections on the sesquicentennial of our Department of Global Health and Social Medicine, quote, proponents of social medicine have long appreciated the fact that social forces, poverty, racism, gender inequity, incarceration, political neglect, economic inequality, other such relations of power, have a part in determining who falls ill, who lives to get better, and who dies, unquote. In both these reflections and throughout his scholarship, and drawing from Johann Galtung and from Latin American liberation theologians, Paul often invoked the notion of structural violence, focusing on historically mediated inequitable distribution of such forces and outcomes, and how certain individuals and populations were placed in harm's way, their agency curtailed in the process. Importantly, this led for Paul, and for many in our department, to the moral obligation to confront such forces and to care for and accompany those impacted by them. Given its centrality to Paul's writing and work, and its relationship to the efforts of so many within or inspired by our department, Jen Pusetti, Salman Khashoggi, David Jones, and I, with Paul's input, had first envisioned this final panel of our department's 150th anniversary symposium series over a year ago. It was been held the first week of March, with Paul as one of our panelists. Instead, of course, now serves as a tribute to Paul, but also as a way to demonstrate and further examine how the notion of structural violence, along with concepts like social suffering, continue to ground and shape the work of leading scholars and clinicians today. It's intended to use the words of Paul's own teacher, Arthur Kleiman, to serve as an illustration and examination of how to link critical scrutiny to ameliorative action. We've thus gathered a remarkable panel today to discuss how Paul and the notion of structural violence have shaped their own thinking and work. We'll lead off with Arthur Kleiman, the Esther and Sidney Rabb Professor in Harvard's Department of Anthropology, Professor of Medical Anthropology here at the GHSM, and Professor of Psychiatry at HMS. He was our department chair from 1993 to 2000, and as those who were present at or watched this beautiful tribute to Paul on October 1st will recall, Arthur was both teacher to Paul and grateful student, and he'll further frame Paul's and his own thinking on structural violence, social suffering, and such links between critical inquiry and action. Arthur will be followed by Bisola Ojikutu, who has certainly linked such scholarship to action, whether in Boston, in Massachusetts more broadly, or globally, and efforts directed against HIV, and COVID, and support of health equity more generally. Along these lines, in addition to being an esteemed associate professor of medicine and global health and social medicine at HMS, Dr. Ojikutu has since 2021 served as the executive director of the Boston Public Health Commission, the oldest public health department in the nation. Dr. Ojikutu will be followed by Joseph Gahn, professor of global health and social medicine department, professor of anthropology in the Faculty of Arts and Sciences in Cambridge, among many other roles, the director of the Harvard University Native American Program, or HUNAP, and a member of the National Academy of Medicine. Professor Gahn has collaborated with American Indian and other indigenous communities to rethink community-based mental health services and to harness traditional culture and spirituality for advancing indigenous well-being. And he has long engaged in examining and working to overcome the impacts of historical trauma. And finally, Professor Gahn will be followed by Dr. Kimberly Sue. Dr. Sue is another of the famous graduates of the Harvard Medical School Social Science MD PhD program, specifically in medical anthropology, and having examined the intersection of US prison systems, addiction policy, mental health, and drug treatment. She is presently assistant professor of medicine at the Yale University School of Medicine and medical director of the National Harm Reduction Coalition. And in true Paul Farmer fashion, she'll be coming to us directly en route from the clinic on our way to the airport for a conference in Puerto Rico on harm reduction. So Paul's spirit and energy certainly lives on among us in many ways. For audience members, please feel free to submit questions at any point for our panelists, and after their talks, we'll get to share these with them during our group discussion. And just as a reminder, we're recording the program today. We hope that you will subscribe to our YouTube channel, HMS Global Health and Social Medicine, to be notified whenever we load new content like today's symposium. With that, it's certainly my honor to get to turn this over to Arthur Kleiman. We had trouble from our end in getting Arthur's video to work properly, so he's going to come to us through what he has to say, which of course is the most important part. So I'm honored to hand over to Arthur.
Fine, thank you so much, Scott. And this is going to be a wonderful panel. I don't want to take too much time from it, but I want to point out the place of structural violence in the context of the Department of Global Health and Social Medicine. When I returned to the department as a full professor in 1982, the idea that social disadvantage and health problems are interrelated was a core theme of what the department was about. Such giants in the field as Leon Eisenberg, Julie Richmond, Rashi Fine, built on this abiding social medicine theme to argue that the solution to such difficult social health conditions had to combine social policies with health policies. My own set of anthropological work in medical anthropology, colleagues, Byron, Mary Jo Good, and others, and I developed this idea further with an understanding of social suffering. And that idea was that social problems and health problems were essentially so interconnected that they should be regarded together. That when you're ill, your illness is interpersonal, not just simply personal. That large-scale social and economic and political factors affect small-scale local worlds that people live in. It's to put those at disadvantage, in harm's way, etc. And also the idea that the very institutions we create to respond to health problems sometimes intensify social health problems. But it took Paul Farmer to insist that poverty, racism, colonialism, imperialism, and the latest phase of capitalism were at the core of the structural violence done to the poor, especially poor people of color in Haiti, Africa, and among disadvantaged groups in the United States. How to relate structural violence to historical trauma and its current consequences is a concern of our department that Professor Gahn will, I'm sure, address in detail. But the notion that social and cultural forces need not be treated as distant and amorphous, but could be analyzed in their detail and as they affect both individuals and populations, is the core of that notion of structural violence relevant to our subject and our field. And now today you're going to see our colleagues, Dr. Bisola Ojikutu, with her tremendous understanding of how these factors work right here in Boston. Professor Gahn, as I've mentioned, and Dr. Su, who has worked extensively on the intersection of drug abuse and structural violence. With that, let me just say that I hope there'll be time for a discussion at the end where we can get into some of the issues that Paul was most concerned about in terms of moving from an understanding of social disadvantage and health disadvantage to solutions. Paul was very much oriented toward solutions, and that has been a key part of what our department is about. Let me turn things over now to Professor Gahn.
Arthur, thank you so much. And we're actually going to ask Dr. Ojikutu to go next.
Oh, okay.
Okay. Yeah, no worries.
Sorry.
Great. Thank you for that.
Great. I share my. Okay. Good afternoon, everyone, and thank you for that very kind introduction. And thank you. I'm really honored to speak with everyone this afternoon. I would really like to focus this very brief talk, not just on my work, but on the work of my colleagues, my very talented colleagues within the public health department here in Boston. And, based on what Dr. Kleinman said and what, my experience had been with Paul Farmer and his focus on both scholarship and action and solutions, I do want to focus my talk on actions and the things that we've actually done. So what have we done here locally in Boston, and what are we doing on an ongoing basis, and what are our future directions? I'm going to highlight two efforts that I would like to share with you just as we think about how we can actually address structural violence. The first is our efforts to address systems failure in both housing and substance use care and treatment. And secondly, our management as we've been in the this COVID-19 pandemic for more than 2.5 years, and what has that meant in Boston, and how has it changed and shifted our focus, particularly towards communities who've been made vulnerable. So that's where I would like to go, and hopefully there'll be time for discussion. So founded in 1799, the Boston Public Health Commission is actually the oldest public health department in the country. And it's been a forerunner actually amongst health departments in its commitment to social justice as well as human rights and addressing underlying social determinants of health within populations. Back in the 90s, well before others were even using the term equity, the commission was utilizing an equity framework in its programming. And in the early 2000s, there was actually an intentional shift to focus on racial justice and to engage and work across city departments to address structural racism. And much of this work is ongoing because there's a lot more to do, and it's certainly highlighted the need for increased partnerships, community-based resources, capacity building, services including housing and access to healthcare, all of these things that have been missing, all of the systems that have failed, and all of which are focal points for our various initiatives. More recently, we have highlighted the need, and I think a lot of this has been, from my, working at the Brigham in the Division of Global Health Equity, really structuring things around structural violence. And for me, that's really an all-encompassing term. And it's really an intentional addition, not really a shift in terminology as well as in action, which describes the ways in which social, economic, and political systems have exposed particular populations to risks and vulnerabilities and has basically inhibited them from reaching their full potential. So I think a really important aspect of structural violence is really about trauma and how do we address trauma within many different communities around the US and certainly many communities here in Boston. And I think the other piece is that, and this is something we have to combat regularly in departments of public health, is that this type of trauma and this type of violence have been completely normalized and accepted as part of our system. And I think it speaks to the moral obligation that we all share and that Paul Farmer lived for, that we're intentional about including our perspective on structural violence in our work. So that's what I'll try to share with you. So at the Boston Public Health Commission, we've used systems failure as a manifestation of structural violence. I mean, this includes failure within the healthcare system to acknowledge that social, economic, and political systems are playing such a significant role in our patients' lives. And certainly within the criminal justice system, where persistent inequities exist for Black and Brown individuals. And we spent a lot of time working on housing policy, which I'll talk a little bit more about. And it certainly failed to help people and has left a lot of people with substandard housing who are, also transiently housed or homeless. And then of course, our educational system has left many behind. So all of these system failures increase disease risk and lead to poor health outcomes. In Boston and elsewhere, a clear result of structural violence is disparities in life expectancy. So the map on your left shows life expectancy at birth by neighborhood in Boston from 2016 to 2021. And please note that these data are preliminary. We finished, analyzing these data a couple of days ago, and it's actually different from previous data that's out there. So we will have this online soon. Essentially, if you look around Boston, Mattapan has the lowest life expectancy overall. And of note, the population living in Mattapan is largely Black, and it's also home to the largest Haitian community in Massachusetts. And by gender and race and ethnicity, you can see on your right that Black males in Boston have the lowest life expectancy. So none of these data are surprising. It's not as surprising to anybody here in this audience. There's similar data elsewhere, across the country, throughout the world. But these persistent disparities, they just can't be ignored. We need actions. We need solutions to address them. And I think that's what's important, what we should be doing at the city level and within our public health department. So what have we done? Well, as a city, Boston has made some significant efforts in recent years to address structural racism. So in 2020, the former mayor of Boston, Marty Walsh, amid ongoing protests over the murder of George Floyd, he declared racism a public health crisis in Boston. And across the country, many other cities and a few states have made that similar proclamation. And frankly, I can say with confidence and with disappointment that most haven't implemented many strategies to support their proclamation. This was just something that was said. Here in Boston, I think we have taken some steps forward. So this announcement actually included a $12 million investment, which was allocated towards decreasing the racial wealth gap, decreasing food insecurity, which was clearly an issue that was amplified during COVID, early days of COVID, developing mental health programming and mental health crisis response, as well as increasing disease prevention and reducing chronic disease. So certainly $12 million is not a lot in the midst of a huge citywide budget, but it is something. It is something that says that there is a commitment going forward within our city. Specifically at the Boston Public Health Commission, we use some of these funds to do work with in terms of institutional racism. We established an Office of Racial Equity and Community Engagement. We developed an anti-racism policy. We continue to administer community investment grants, which isn't done in a lot of other places because we realize that so many of our community organizations are struggling, and they are the people who are addressing and meeting the needs that are have been caused by structural violence head on. We've also increased direct service provision related to social determinants of health, and we've enhanced our data because if you can't measure it, you certainly can't address it. So that's certainly something that I've been working on since I started in my role about a year ago. And so most recently, when our new mayor was elected, she intentionally selected a very diverse cabinet of leaders. And I intentionally make this point because I think that, oftentimes we can be diverse and, kind of say, okay, that's great. We have a lot of different people, different perspectives, different lived experiences. But I do think this is important because my experience with these, new leaders here in Boston is that, many are really focused on the impact of structural violence on communities that have been made vulnerable here in Boston. And it's that concerted effort, it's that citywide effort, it's the systems level, it's the structural level where change will actually be made. So turning to the two specific examples that I wanted to review. First, let's talk about substance use disorder and homelessness in Boston. So what you see here, these are the streets that comprise an area that we call Mass and Cass. It's sometimes called Mass and Cass in a derisive way. I mean, in a negative sort of perspective about what's happening there, and people call it methadone mile and other sorts of things. Most people who live in this area are living with substance use disorder and co-occurring mental illness. Those blue cones that you see there are tents that previously existed. People were living there. They had set up shop. They, some of them, when I say set up shop, there were people who were selling items, sort of developed a community, and there were certainly, people who were selling drugs to people who were living there too. So again, it was a community. And what we did earlier in this year is we did a housing initiative. We essentially housed about 150 people. We moved people from the tents into low threshold housing. And we did that because it was safer, and because we know that the housing system is broken and otherwise they would still be living in tents. So we made an intentional effort. We found the funding and we moved people into housing. And since then, many have moved on to permanent supportive housing. Many are on the road to recovery because housing is such a critical piece to the puzzle. It really is something, if it's missing, then everything else, also is never going to be resolved. And obviously outcomes are at risk if you are unhoused or have transient housing status. So this is actually a first in the country model to provide services to individuals living with substance use disorder. And it's a way to provide comprehensive services, as I mentioned, to help people on their route to recovery. So though many of those tents are now gone, because as I said, we move people into housing, more have arisen. And so this is really an up close view of what's happening now on the street. We have people who are still, living in tarps. So essentially what I'm saying here is that we made a dent in the issue. our actions, I think, were intentional. I think they were important. I think it was an incredible structural initiative, but it's a dent. And systems are still failing because there's so many systems that are contributing to what's happening on the street. But what about structural violence? So we talked about the housing piece, but if we're talking about people and really what's happening and the confluence of social issues that are causing the problem here in terms of unhoused status and substance use disorder. So if you look at issues of race and ethnicity, what you find is that, interestingly, a lot of what's happening in terms of the face of opioid use disorder in the US and the media, it continues to be white. But if you look at people who are out on the street here in Boston, I would go so far as to say in many encampments, unhoused status throughout the US, the vast majority are actually people of color. So this is actually data from a survey that we did in May of this past year, and 66% were either Black or Latinx. So what does that mean in terms of how we approach this, and why is this important? What it does is that it highlights the impact of structural violence on communities of color. There's a disproportionate burden of substance use disorders amongst Black, Latinx, and Indigenous populations in this country, and we should be well aware of this. There's an overrepresentation of Black and Latinx individuals who are experiencing substance use disorder who are homeless nationwide. And that inequity mirrors what we found when you look at any of the system failures that I described. And in addition, treatment for substance use disorder, all the places we talk about, all the medication that we use for replacement, whether it be Suboxone or methadone, it's less available in neighborhoods with higher proportions of Black, Latinx, or Indigenous populations. And there's increased stigma associated with accessing substance use disorder. So what do we do about this beyond the housing? Because I said that was one step. We made a dent, but what do we really need to do? So we need to have intentional approaches regarding equity. You can't just say, okay, this is inequitable, let's do something about it. We really have to be intentional. We really have to pay attention to what's happening in order to provide equitable access to all the continuum of services that you need to get people on the road to recovery and to put them sort of in a better state in their life. So luckily, we received a 3-year grant from the Office of Minority Health to study our work and to work towards more equitable access to services, which we'll see what happens. But in the meantime, what we're doing is putting an enormous amount of effort into working with communities of color around Boston to decrease stigma, to not just focus on the Mass and Cass area, but certainly go beyond Mass and Cass to other neighborhoods in Boston where people are also suffering. They are unsheltered or homeless or experiencing substance use disorder. So I want to turn briefly to the second example, so COVID-19. I think that it's really important for us to talk about not necessarily where we were, not necessarily, where we've been, but really where we're going. So I will start with one thing that I think is important. We should all know this by now, but I think it's really important because I'm going to talk about it from a local perspective. Amongst Black individuals in Boston, the proportion of COVID-related deaths since the beginning of the pandemic is significantly higher than the proportion of Black individuals citywide. And this is something we've seen over time. Obviously mortality has decreased, but it's certainly not something that we can say has been solved in any way. We still see this disproportionate increase in mortality. I think that there are, as we all well know, many reasons for the disparities in mortality, lack of access to care, high rate of essential workers, amongst people of color, and many other reasons, certainly lack of trustworthiness and medical mistrust and other things that we know are out there. But as we've figured all of this out, what is it that we can do differently going forward? Because again, we want to be action oriented. We want to figure out what it is we can do differently as we move towards the future. Well, what I would say is that if there's anything positive that arose from COVID is numerous lessons learned regarding how to address structural violence and systems failure within communities of color, at least in the state of emergency. In that state, partnerships were formed between community organizations and academic institutions, as well as in our public health department, strategies to build trust, trusted messengers. We were out there, talking to people. We promoted equitable implementation of different strategies. And I think that there was sort of a heightened need because we were in the setting of emergency. And that's great. And I think that's important. And it's a great lesson that was learned, because what we saw was that we've narrowed the gap in terms of vaccination status. And we have, as I mentioned, decreased the mortality disparities. But what do we need to do going forward? You know, how do we take those lessons learned and then build towards something better, build towards truly addressing structural violence and really addressing the pervasive disparities that we've seen for such a long period of time? Well, I created this graphic just to show you that, you know, we need a lot of things. You know, we need sustained funding, we need sustained momentum, neither of which we necessarily have, but it's a need. I think people are aware of it. We need investment in public health infrastructure. We need better communication and actually transparent communication. I think that we're getting better with that, but it's certainly not where it needs to be. We need to continue to promote diverse representation as we you know, tackle other inequities. And what I would say that's really key here, and that reminds me a lot of what Paul Farmer talks about, is just equitable partnership, you know, working with people, you know, working with communities, letting communities lead, shifting the power, shifting the ownership. I think those are key lessons that we should have learned. And I hope that we're learning, if we haven't completely learned it yet, and that we will, you know, take as we move forward and look at other issues that we're dealing with. I think from the standpoint of our public health department, our focus really remains on community mobilization. It remains on community engagement and these issues of empowerment and ownership. And we're trying to move things forward as far as those issues are concerned, because this is what will truly address structural violence. And from my perspective, I think the mobilization that we saw really did lead to change creation in Black and Brown communities around Boston. And again, I think the real challenge is sustaining this momentum as we move forward. So in terms of what's next, at least from the public health perspective, and I'll throw in some of my, you know, concerns and my, you know, goals as we move forward. Certainly, we are going to continue to focus in on housing policy and new strategies to address substance use disorder, particularly for Black and Brown individuals. We're prioritizing mental health as a public health crisis, specifically youth mental health, and we know that has been born of years and decades of trauma within our communities. Retaining and engaging people in care for chronic diseases. We're working on mobilizing community health workers, people who go out there and they do the work and they meet people where they're at, all things that we certainly learned from Paul's work. And then, you know, when we think about reparations and what does reparative justice and health actually look like? You know, what does that mean as a strategy? We've begun to engage in those conversations citywide, and I think it's going to be very very interesting to see how that rolls out in Boston, given sort of Boston's history. So all of these are high priorities. And I wanted to end with my favorite quote from Paul, that the idea that some lives matter less is the root cause of all that's wrong in the world, because it's so profound, but it's just very simple, you know, and it's really the driving force for most of what we do through our work at the public health department. And the reality is that we can't afford to allow some lives to matter less. I mean, we need to be intentional in our actions to ensure that every life matters. So I will stop there and say thank you.
Professor Ojikuda, thank you so much. And really, we're so grateful to you for leading our city so thoughtfully in this respect. And just a reminder for our audience members that if you have questions for later discussion, feel free to put those in through the Q&A function. I'll next hand this over to Professor Gahn.
Thanks, Scott. Just looking to make sure we're good here. And I've got my slides going, but I'm not seeing them. So I wonder if you all can see them okay?
Joe, I see them fine.
Fantastic, thank you. Thanks for the invitation today to join this important panel that was delayed by our deep loss of our chair. And I'm grateful today to visit with you today about Indigenous historical trauma, progress or regress in addressing structural racism. And I want to start with just an acknowledgement of land and people. I'm the faculty director of the Harvard University Native American program, Scott said, and we work closely with the Massachusetts people here in the Commonwealth to develop this acknowledgement. Harvard University is located on the traditional and ancestral land of the Massachusetts, the original inhabitants of what is now known as Boston and Cambridge. We pay respect to the people of the Massachusetts tribe, past and present, and honor the land itself, which remains sacred to the Massachusetts people. And the Massachusetts people are Indigenous people. And in particular, I'm going to be speaking today in the context of the United States, where Indigenous people are predominantly grouped together as American Indians and Alaska Natives. So American Indians and Alaska Natives, of course, are the surviving descendants of Indigenous peoples in the USA. This is a class of people who have exhibited terrific diversity over the course of history. Primarily, we have benefited from a huge demographic rebound. Prior to European arrival to the so-called New World, there were perhaps as many as 5+ million of us in the contiguous United States at 1492. But of course, European arrival resulted in the decimation of our populations. We bottomed out at about 240,000 people in 1890, 1895, that area. But we've exhibited a tremendous rebound in this past over a century. The most recent US Census, for example, found that 3.7 million people in the United States identified as American Indian or Alaska Native alone. If you threw in with some other race, you would get a total population of about 9.7 million people. So obviously, there's been a lot of growth over the past period of time. The reason that we underscore American Indians and Alaska Natives is that we have a very distinctive relationship to the government of the United States that comes from a history of treaty making. And so there are 580 or so what are called federally recognized tribal groups or tribal nations in the United States. And these tribal nations are semi-sovereign and through law and policy and the history of treaty making maintain this very distinctive relationship to the United States. And so that's why out of all the Indigenous people of the United States, some of might who be Latinx who would identify as Indigenous or Native Hawaiians, there is a kind of distinctive setup here that is why I focus in on these groups. We are concentrated predominantly in reservation settings or in certain urban population centers due to the kind of history that I can unpack later if you like. That does mean that probably over half of the people who identify as Indigenous are not living in an identifiable Native community. And so, you wouldn't learn a lot about them through surveys or research because we don't exist in concentrated enough numbers for that to be picked up. The important thing for today's conversation is to acknowledge and recognize that American Indian and Alaska Native peoples have been colonized, first by obviously European powers, but eventually by the United States. And colonization has entailed violent dispossession. Really, land was the foremost driver of our colonial subjugation, access to our land and removing us from that land. And this long history of violent dispossession, which included sometimes military confrontations, certainly squirreling us away on reservations out of sight and out of mind, where there's not enough resources to really support a community for a period of time, starvation. These sorts of things have had tremendous community impacts. And you can't go to any Indian community today and not have people there be able to recount for you what that particular history was for them that have resulted in what today get picked up in research as mental health inequities or disparities. And so in particular, we contend with unequal rates, disproportionately high rates of addiction, of trauma, of suicide in terms of mental health problems. And what's interesting is that we have witnessed the rise in the past 30 years or so of an alternative or alternative explanatory accounts for these mental health disparities that really rival, contest, recast the way people in mental health professions, psychiatrists and psychologists and social workers talk about this legacy of colonization as it gives rise to mental health disparities. So historical trauma is the way that this has been discussed, and the early publications that mentioned historical trauma began to appear in the health literature in the 1990s. You had Eduardo Duran writing about what he called the soul wound, which had to do with this historical impacts that then traced down through people's lives into current generations. Maria Yellowhorse Braveheart, a Lakota social work researcher, coined the term historical trauma, really for the same concept. Together, they worked and developed this construct out and published together around really finally labeling it as historical trauma. Now, there have been a lot of subsequent refinements and elaborations in this concept since the 1990s. The things to know are that it's heavily promoted by Indigenous health scientists and professionals, especially in the mental health domain or maybe the behavioral health domain, if you expand to include, say, diabetes. But it's really been led by Indigenous health scientists promoting this and then being accepted by lots of other non-Indigenous health advocates and researchers, so that it actually is pretty ubiquitous in the scientific literature about Indigenous health disparities at this point. And importantly, it's increasingly ubiquitous within Indigenous communities as well. So it's not just a scientific or a researcher concept. It's actually been taken up and promoted and circulated in Indian country in the United States, but also Canada, Australia, New Zealand. So anywhere you go in the former British Commonwealth nations, you will find this reference to historical trauma in a way of talking about and explaining or accounting for Indigenous health issues. So what is historical trauma? I mean, essentially, to understand it, you're recognizing it's a fusion or a wedding, a blending of two very familiar constructs that we've had for a while. It's really putting together of historical oppression and psychological trauma. You put those together, you get historical trauma, which recognizes the past as giving rise to the present, and of the psychic impacts of that oppressive past. Really, I think if you were to distill down the purpose for doing this kind of fusion or blending these constructs, there's fourfold reasons why. The first was, try to account for and explain for why there are these particular kinds of health and mental health inequities in Indian country. Addiction, trauma, suicide, those are the kind of things that come from, you might say anomic despair. They come from, when your society collapses or your livelihood's taken away, those sorts of things. And the problem with mainstream mental health professional views on these issues is that, of course, it was medicalized. It was very individuated. It was about a patient and a doctor. And so this provides an account then that explains these health disparities by recontextualizing or re-socializing these health problems within a broad spectrum of history and experience. In that sense, it could help to resolve the sorts of paralyzing self-blame that too often happen when people contend with these problems in this form of suffering, where they just think they're deficient or bad people and get trapped in not really being able to do anything about it. But once you reframe this within the context of history and of community, then that can be punctured or broken through in a way that can help people to, maybe take action. And it also was understood and designed to legitimate Indigenous therapeutic practices, to allow for the practice of ceremony and the sacred activities that circulate life and health and so on. Now, historical trauma, of course, is in some ways an elaboration of post-traumatic stress disorder, which appeared in the DSM in 1980. And yet it was seen to go beyond, to extend our notions of PTSD to account for a different and more complicated or complex form of experience. And so we might recognize what we say are the 4 C's of historical trauma that really distinguish it from PTSD as it appears in the DSM. The first is that historical trauma originates from colonial injury. And so this is really about capturing and anchoring mental health inequities today as colonial in origin through histories of subjugation. The second, that it's collectively experienced. It's not this individual or that family, but entire communities who have experienced this colonial injury and who therefore have been injured or wounded by that history. It is understood to be cumulatively escalating. So usually this is not any kind of one-off event. It's a whole sequence of events over time in which first it's being chased by the military, then it's being impounded on a reservation, then it's starvation that follows from the government not delivering on its promises, it's disease, it's et cetera, industrial boarding schools that children were kind of coercively sent to for, assimilative commitments and so on. So cumulatively escalating. And finally, most importantly, it's cross-generationally transferred. So really, this is about trying to account for how ancestral experiences of colonial injury pass down through lines and somehow place current day generations at risk for greater kinds of problems or suffering that can be recognized or marked as mental health problems. So this is really what this construct is trying to do, where it comes from and what its purpose is. Obviously, there are some implications here for mental health treatment that are really important to recognize. And I'd say that main thing to underscore is that reframing mental health problems in Indigenous communities allows for an expansion of therapeutic possibilities. So now it's not, just psychoactive medication or counseling and psychotherapy. Really, this is kind of postulates an implicit mechanism of what we might call post-colonial anomie. Anomie, as you know, means no law. It means like a loss of identity, purpose, who you are, where you belong, what you're supposed to be doing, what's a good life, all those kinds of things that happened through the colonial encounter. And so a big part of therapeutic possibility in Indigenous communities today is, also about reclaiming robust Indigenous cultural identities. The return to kind of Indian pride happened beginning in the 1970s with the American Indian movement and the Red Power movements, really underscoring and emphasizing a connection to tradition and the pre-reservation ways of life, and finding continuity with those and bolstering a robust cultural identity. And part and parcel with that is this return to forms of Indigenous, traditional practices. A big part of that is the sweat lodge ceremony, for example, or pipe ceremonies, or the Sundance ceremony, et cetera. Different tribes do have different traditions here. Some of them have really broken out almost in pan-Indian fashion. It's the case today that almost everywhere in the United States, every community probably has sweat lodges happening, which wasn't true pre-reservation life, but it is now. And yet all of that is understood to be part and parcel of healing and therapeutic benefit, relative especially to countering historical trauma and its impacts. This has given rise to this claim everywhere I go in Indian country and interface with mental health folks in the field, Native mental health folks in particular, who will say, we don't really need the latest, greatest evidence-based practice or empirically supported treatment from psychiatry and psychology and social work. Our culture is our treatment, which is to say that people are claiming that looking back and rehabilitating, revitalizing, reclaiming these Indigenous ceremonial practices, which are understood, implicitly to circulate life and to benefit people who participate in them in therapeutic fashion, as well as, more direct forms of traditional doctoring or medicine practices, are what we need to turn to remedy the inequities that we face in our communities as a result of colonial subjugation. And this gives rise, of course, to this broader interest or pursuit of so-called, decolonization of healthcare. There's a lot of interest in the academy, in particular in decolonization. It's not a term I hear so much in Indian country or in communities themselves. But I think that the anti-colonial impulse is certainly what's going on here, whether we frame it explicitly as decolonization or not. So let me just summarize then conceptually what I try to share with you about historical trauma to kind of get at its basics. It is a health discourse by and large. Obviously, it kind of proliferates. People take it up in other domains and fields too, but it's been originated and primarily for Indian country and primarily been underscored as a health discourse. It's been promoted by health researchers and health professionals. It's focused on healing and the therapeutic by drawing heavily on Indigenous cultural traditions and practices. And so we see here in this promotion circulation of Indigenous historical trauma an emphasis on culture, on tradition, on healing. It's been both local and international in its appeal. I mean, anyone who goes home to their community or in any place where Indian people are gathering around health, it's a concept that's familiar, that people use, even as it's circulating more broadly every day. And it anchors what I refer to as an alternative mental health discourse, or what I sometimes call an alternative science. Now, there's not time to do justice to this today. It's a different talk, but alternative, I presume you get an Indigenous, but science, as you see spelled here, is really an overt reference to the fact that the authoritative knowledge of the sciences, that is psychoanalysis, psychotherapy, psychology, psychiatry, runs far ahead of what we really know based on data by anyone's standard. The creation of the DSM and the classification of 300 different mental disorders, like maybe a dozen or two of those are actually studied in any real depth. We don't really understand where those disorders come from, the etiology, which you would want, and much of medicine favors as the primary way of accounting for disorder. So the knowledge we have runs far ahead of the evidence we have been able to generate. And that means that this is a site where a lot of consensus, a lot of assumption, a lot of orientation comes to play in what is considered the authorized knowledge of the sciences. And so in some ways, because we recognize that so little is known about fundamental questions in psychiatry and psychology around mental health issues, I'm really talking here about an alternative Indigenous science in which these four domains are contested and recast by Indigenous people as a kind of parallel explanatory framework for mental health issues that is sort of parapsychiatric, but not accepting of the main tenets of psychiatry. So these four domains I put here are distress, well-being, treatment, and evaluation. And in this form, for distress, it's not mental disorders, certainly not DSM disorders, but historical trauma is really the way people kind of talk about this. And that's what I mean, that this is an alternative anchoring of a mental health discourse that runs parallel to psychiatry. Historical trauma is, the way people talk about distress now, not so much DSM. And I think it trickles down to these other domains as well. For well-being, it's not, trying to attain or achieve a form of neoliberal individualism, but rather persisting and maybe reclaiming, in some instances, indigenous relational forms of selfhood or self-configurations that are sociocentric more than egocentric. With respect to treatment, it's not really a celebration or investment in evidence-based practice or empirically supported treatments, but rather an indigenous traditional healing and figuring out, how to reclaim and revitalize some of those, or basically even just how to apply or incorporate or integrate or interface them with health services systems in some way that doesn't do damage to them. And finally, evaluation, even the question of what works for whom, is not really premised on better scientific outcome assessment in Indian country, but rather increasingly on indigenous ways of knowing, indigenous knowledge traditions, again, that have continuity with the past, in which maybe first person personal experience is really the highest source of authorized knowing. So there's more to talk about here if you want to, and there's, as I say, there's a lot that could be unpacked, but let me briefly turn now, and I'll skip most of this because I don't think we have time today, but we have done a systematic review to try to analyze the research literature on historical trauma as it's been measured and demonstrating whatever health impacts there have been on Native community respondents. And the point is that there are studies out there that have done this. The measurement issues are a little bit funky. And it really raises the question ultimately of whether Indigenous historical trauma is properly conceived as a sort of scientific construct that can be assessed and measured and can be implicated causally, cause and effect over history for health inequities today, or whether Indigenous historical trauma is really more of a symbolic, a metonym, in fact, or sometimes you might say a metaphor. It's just a way of talking and expressing Indigenous suffering today that keeps it socialized and contextualized in important ways. And in this is a systematic review, I sort of come at the end and sort of suggest that it doesn't look like it's necessarily going to be harnessed in terms of like a causal social return of health and the way people talk about that. Although I should say that we're going to be having at our seminar in December, a Native researcher coming to talk about some work that she's been doing. This is Amy Bombay from Canada, who has been looking at the kind of causal impacts over time. So I invite you to pay attention to that. But let's say, for sake of argument today, that it's not really being posited in the most serious fashion as a kind of causal source that can be traced scientifically. What then is going on with the popularity of historical trauma as it's been taken up and circulated? And I want to suggest to you that historical trauma really is kind of a novel form of claims making, that Indigenous people have been subjugated, have been victimized, have been dispossessed, and have been long subject to injustices of various kinds. And of course, people are about trying to get remedies for this injustice, about getting a hearing and acknowledgement and hopefully repair, maybe reconciliation, if that can follow from true action that would make these sorts of issues taken seriously. Psychological trauma has long historically been linked to claims making. Psychological trauma as opposed to physical trauma, the way medical doctors have talked about it for a very long time. Trauma made the jump from the body to the mind in the 1860s or so in UK, where train crashes were happening for the first time. People would stumble off. There would be things wrong with them that no doctor could pinpoint at the time. And, was it neurological? Or at some point, people started to wonder, was it psychological? And so trauma became, not just an injury to the body, but an injury to the mind historically. And so historical trauma is really harnessing this function by psychologizing the oppression of Indigenous peoples. Part of the psychologizing is an effort to speak to mental health disorders and mental health problems, which of course have a psychological domain to them. But it's also about taking that oppression and then being able to link it to injury or to woundedness at the kind of psychic level, because this intergenerational psychic injury of ancestors and descendants sharing these kinds of experiences can provide a justification for damage and repair. There's a way that this can be harnessed to make a novel form of claim, not the same old hat that we've been saying all the time, but it gives us a new language and a new concept, at least 30 years ago it did, to try to get a hearing again and to try to see if we get some action and some recognition and some repair. So I think part of what is going on here, at least, is that historical trauma affords a novel rhetorical strategy for longstanding demands by Indigenous peoples for remedy and redress. Which is all good. We have to reinvent our language. We have to continue to find ways to seek justice and to language our messaging in ways that will get a hearing and hopefully trigger and let loose resources to work toward reconciliation of some way, shape, and form. The question that remains is simply what are the limitations or pitfalls of doing this in some way? And I think there are some potential unforeseen consequences that merit scrutiny and consideration. I mean, one thing that historical trauma kind of does is it sort of essentializes indigeneity. What you don't see in this literature are people saying, well, Lakota people suffered a massacre at Wounded Knee by the US Army in 1890. And, descendants of the actual massacre victims or descendants of family members who had relatives who were lost, might be expected to be impacted by this event more so than other Lakota people who weren't there, who only heard about it. It's not that it wouldn't affect everybody, but you might expect differential impact depending on how close it was to your own ancestors. But no one's doing that. Historical trauma is really just taken to be about Indigenous suffering in the wake of colonial subjugation, in general terms. And so if we all have historical trauma, what does that say if we're really concluding that all Indigenous and Native people in the United States are wounded, are injured psychically, and carry this form of what really is almost like a risk factor for current day mental health problems? And what if that's not entirely warranted? It also often plays into a biologization of suffering, in part because people are looking for how is historical trauma passed from ancestral generations to current day people. And there's a lot of enthusiasm about epigenetics today as a potential way in which suffering and the legacy and impact of colonial subjugation could be passed from 4 generations back to people today. My acquaintance with the epigenetic literature suggests we're not close yet to identifying this sort of transfer mechanism across multiple generations in this way. Certainly, it looks like good evidence for in utero throughout your lifespan and those kinds of things, maybe mother to child in some way. But, the heralding of this mechanism, I wonder if that's really warranted here, because biologization of mental health is sometimes thought to potentially help people who are suffering contend with stigma. But, with schizophrenia, where there was a concerted effort to try explain schizophrenia and remind society it's a brain disease and people, shouldn't be stigmatized because they have schizophrenia, it sort of backfired. People ended up holding more stigma if someone had a brain disease or a brain disorder than if they were seen to have, other kind of different framing around their suffering. Finally, it's really about medicalizing the social. The psychologization of Indigenous suffering is sort of about construing this as a mental health issue or a health issue more broadly. And of course, that's because that's where the resources are. The revolution is not going to be funded by the federal government, but what the government will and what what there's a whole system to do is to help people with their health problems. And so on the one hand, it's sort of riding this boundary between the medical and maybe getting out into broader social justice struggles, because the resources are in the medical, and the social justice struggles are harder to keep moving without resources of the same variety. And so I think there's a participation in the medicalizing of the social, even as it's trying to re-socialize and recontextualize in ways that push at what that medicalization might look like. But in any case, medicalization is typically individuating. It's typically construes, it's like a Jedi mind trick that recasts, historical oppression or injustice as sort of a problem that a doctor and a patient should solve in the consulting room. And so we have to ask ourselves, to what degree is it really accomplishing its purpose through potentially extending too far in medicalization. So I think about this kinds of things. And so if you want to learn more about this, I direct you to my website. This is my family surname, gone to war. And so I'll leave you with this, and thank you for your attention today, and looking forward to greater participation as we proceed with the panel. Thank you.
Professor Gahn, thank you again so much, and for thoughtfully, again, connecting critical scrutiny with corrective actions and all the nuance. So just very grateful to you. We're next going to hand off to Dr. Kimberly Sue. And again, for everyone who missed the introduction, she is doing this in true Paul Farmer fashion, catching us on her way to the airport, perhaps right now at the airport, and we'll be changed from phone. So Kim, I'll hand off to you before you get into security.
Thank you so much. So my talk's entitled The Structural Violence of Overdose Deaths. Can you hear me okay?
Yes, totally. You're good.
So engaging with the concept of structural violence, I went back to the Johan Galtung 1969 article entitled Violence, Peace, and Peace Research, where Galtung writes, violence is here defined as the cause of the difference between potential and the actual, between what could have been and what is. There may not be any person who directly harms another person in this structure. The violence is built into the structure and shows up as unequal power and consequently as unequal life chances. Paul Farmer, Salman Khashoggi, and colleagues wrote in PLOS Med in 2006 in an article entitled Structural Violence in Clinical Medicine. And they further articulated that because it's embedded in longstanding ubiquitous social structures, normalized by stable institutions and regular experience, they appear almost invisible. They wrote, it does not matter what we call it. Structural violence remains a high-ranking cause of premature death and disability. So here I want to briefly explore the structural violence of overdose deaths that take our patients in the prime of their lives, in their 20s, 30s, 40s, and 50s here in the US, and how every overdose death can be considered structural policy failures. Farmer wrote about the persistence of structural violence in times where, quote, science and medicine continue to yield truly miraculous tools. In fact, we do have a miracle medication called naloxone that's an opioid receptor antagonist, and it reverses respiratory depression related to opioid overdose, and if administered in time can prevent anoxic brain injury and death. In fact, it's not a new medication. It was approved for opioid overdose in the US in 1971 and is on the WHO list of essential medications. However, despite this life-saving medication and life-saving treatments for opioid use disorders, such as methadone and buprenorphine, that cut the risk of overdose and death by half, we are still seeing ever more overdose deaths year after year in our current era of fentanyl dominating the unregulated opioid supply. There is currently a naloxone shortage, which is a separate talk itself, with only 1/3 of people after an overdose receiving life-saving medication. So how can we reverse these deadly trends? Some brief history and summary of overdose deaths in the US that I think are relevant here is overdose deaths in the last 12 months have exceeded 108,000 people, not just opioids, but all substances in this country. Overdose deaths rates have significantly increased for Black, American Indian, Alaska Native people in 2020, disproportionate to what was happening among the white population. So in 2020, overdose deaths increased 44% for Black people and 39% for American Indian and Alaska Native people compared to 2019, according to the CDC. And while the rates for white people were also historically high, the increase was 22%. Again, this sort of reflects structural racism and longstanding issues. Furthermore, a history of substance use was common, but a history of receiving substance use treatment was not. Only about 1 in every 10 American Indian, Alaska Native, and Hispanic people had reportedly ever received substance use treatment. And the evidence of treatment was even lower for Black people, 1 in 12. These are sort of not new phenomenon, as you sort of heard from the previous 2 talks, building off of many of the longstanding health inequities. The racialization of access to substance use treatment, healthcare mistrust, the disparities and inequities are longstanding. Historian of medicine at Columbia, Samuel K. Roberts, has observed that methadone, one of the mainstays of treatment for opioid use disorder, has suffered from neighborhood segregation, neighborhoods already facing concentrated disadvantage, and structural racism. In addition to getting increased access to, in addition to treatment, increased access to naloxone is necessary, getting it into the hands of people actively using drugs and their family and friends, and we can consider these policy failures. Police have advocated to buy up state and local supplies of naloxone, further fomenting a carceral and police-based response to overdose rather than community ones that can be particularly dangerous given how police officers have responded to people experiencing substance use crises, especially people of color, many of whom had died at the hands of police violence, such as George Floyd, who was using fentanyl at the time of his death, Daniel Prude, who was using PCP at the time the police killed him, and Rayshard Brooks, who was using alcohol at the time that police killed him. However, I also want to explore the persistent and devastating harms and violence caused by healthcare providers ourselves, and why the ongoing persistence of stigma in the US against people who use drugs continues to be harmful. I want to explore the convergence of structural violence as a theoretical approach and think about it with indirect or direct violence by our so-called healing professions. Can it be extended or stretched to analyze how how healthcare providers themselves, steeped in culture, cultures of hostility and stigma, use language, actions, moralizing blame to badly treat people who use drugs in the clinic or hospital settings. From my ethnographic work, as well as from numerous studies done with people who use drugs in these settings, many say they would rather die than come see us because of the way they were treated, purposefully needled, their pain ignored or made fun of, called derogatory and offensive language such as, quote, junkie or addict or drug seeker. I received phone calls from people in Oklahoma where a mother with an injection-related abscess in her breast would not go to the ED because of fear of CPS being called. And she told me she would rather die than have her kids taken away. Hospitals and clinicians in this way are sources of carceral and institutional structural violence, often calling cops on people who use drugs during a hospital stay, and people routinely leave them prematurely when what is at stake is their ongoing dignity and respect as they attempt to seek care for such stigmatized conditions and potentially life-threatening illnesses. We must also face up in a reparative fashion to the structural racism of our country's response to substance use, to the predominant reliance on the criminalization of Black, brown, non-white people who use drugs, particularly during the crack cocaine era, and how this continues to negatively impact communities of color to this day, rather than taking a health and public health approach, which is now in vogue as more white people are affected by substance use and substance use deaths, as Helena Hansen's work has shown us. There are also more subtle forms of structural disregard as well. Doctors are allowed to opt out of treating opioid use disorder, for example, despite numerous attempts to get primary care doctors to prescribe buprenorphine, an office-based treatment for opioid use disorder, they still largely do not. A 2015 article noted that only 2.2% of US physicians had obtained the waiver to prescribe buprenorphine. The increased prescription of buprenorphine is actually coming from the same numbers of people doing more, not generalists or other specialists doing a handful that comes across their practice. However, this is condoned by regulations and hospital systems that make buprenorphine a special medication that requires a waiver, one of the few medications in the country that requires such a high threshold to prescribe. Dr. Farmer would know this is nothing new. In the HIV era, clinicians were routinely part of the problem. Many clinicians and policymakers continued the economic and structural arrangements that people around the world did not deserve treatment, only prevention. This call to change is both a moral one, but I propose also a theoretical one as well, as a conundrum of care. Can healthcare workers themselves be what prevents human beings from not achieving their maximum human potential, continuing the unequal life chances of the most structurally vulnerable? I am arguing that we cannot and must not ignore the myriad forms of violence, interpersonal, structural, historical, in which healthcare providers play a part. We must think critically about and call in our colleagues following Dr. Farmer's example, examine the traumas associated with the work that we do as healthcare providers, as Arthur Kleinman's work has shown, with keen theoretical observations and ongoing incitements, in order for us to make any dent in overdose deaths and to walk alongside our patients to achieve long lives and their maximum human potential, rather than be standing in the way. Thank you.
Sue, thank you so much. Clearly, Paul's influence works lives on through such fantastic work. And thank you again for doing this while clearly at the airport. I know that Dr. Ojikutu had to return to another meeting at her super critical day job. But what I have sometimes to ask a few questions to our panelists, and certainly if Dr. Sue is able to still hang with us for a little bit. And Arthur, given your own role in all of this, I wanted to give you the first chance to ask our panelists or start off by any of your own reflections.
Well, you know, I think that what we're seeing is the next generation of ideas and actions that come out of the enormous recognition of the relationship between social disadvantage and health and poor health outcomes. And right now, the focus seems to be on the different ways that illness is created, that care is delayed or undermined, and also, and this is what I'd really ask about, is the upstream changes that are important to remove fundamental disadvantage. So those upstream changes, we heard somewhat in Bisola's presentation of housing. We don't usually think of housing as a health problem, and yet it is obviously a critical problem for health. Or in Joe Gaughan's work, coming to terms with reparations, redistribution, with rethinking land claims, et cetera. I think that, you know, those are big issues. And in the area of, you know, of Kim Sue's work, they loom large as well, that the looking at the interventions we have at the level of women who are women of color who are under great pressure in the social environment. Kim has shown in her own great book, marvelous book, Getting Wrecked, that such women are caught in a cycle between predatory environments and the criminal justice prisons. And the paradox is often the safer place is the prison. And so taking into account the dangerous environments in which people live, the inadequacy of the criminal justice system, I'd ask this question, which is, what do we see as the method going forward of linking those large scale upstream problems that place people at such disadvantage and have historically done so with actual social change in the future?
Great. So either Professor Sue or Professor Gaughan, happy to have either of you go first. I don't know where Professor Sue is in respect to the airport. If you have availability, I'm happy to give you the first chance to answer.
She may be going through security.
Yeah. All right, Joe, it's up to you.
Thanks. It is an important question, and it is the ultimate challenge, I think. You know, the striking thing to me is that while there's no question in any Indian person's mind that the long history of colonial subjugation has put us at risk for the kinds of suffering that we see in our communities, at the same time being able to trace out in cause and effect fashion the lines of impact, the mechanisms by which this gives rise to suffering today, you know, is very, very challenging. I don't know many people who are able to do that. You know, the best work so far, as we'll hear from Amy Bombay in December, in some ways has to do with just trying to find out were your grandparents attending an Indian boarding school or residential school, for example, and to compare people who have grandparents who were and grandparents who weren't, and try to get a sense for, you know, what is their mental health status and standing, for example. And so that while that's illuminating, you know, it's correlational, and therefore it's open to competing interpretations. It may be that, you know, Indigenous residential school attendance is reflective of class differences or vulnerability differences in the family. It may be that people who are in mental health crisis are more likely to center and to report things like ancestral suffering through residential schools or what have you. So the mechanisms, as people talk about them, are really hard to identify. It often seems to me that the mechanistic language itself in, trying to link determinants and outcomes is not entirely adequate. I mean, I think of meaning making. How is it that a person understands their place in their society when they know that their ancestors have gone through this kind of selected out for disparagement and disadvantage and, lives not mattering as much as other lives, for example? And what does that say about who you are and what your prospects are today as a current generation? And in that sense, what if meaning is the mechanism, or what if it has to do with how we frame who we are and where we belong in a current society that has mistreated us in the ways that these societies have mistreated Indigenous peoples? The last thing I'll say is there's really clear kinds of instances where, you can point to the structural elements that give rise, obviously, poverty, but like on most Native communities, federally recognized tribes who hold land bases, which most of our tribes do, in order to protect that land base from further dispossession through like income tax not being paid, or property tax rather not being paid on it, we hold it in trust with the federal government. So lots of Indian landowners have land, but that land is held in trust with the United States because that protects it from their states trying to levy property taxes. And if you're low income, you can't afford the property taxes. And so if the state were to levy the property taxes, they would actually confiscate your land, And so, but by virtue of that land being held in trust, your resource base then is not available for collateral to attract investment in your community by business. And so, I think of my community, the Fort Belknap Indian Reservation in north central Montana, where, for a long time we had a contract with the Army to develop, really assemble spring fingers for landmines. That's the kind of things that we were able to get for trying to have jobs for our people. So there's not livelihood for people on too many reservations because jobs are so scarce, because there's not business, going on in the way that will support enough people. And so that's just one example. Another example is, law enforcement. We have a very difficult, tense relationship with law enforcement, but, the FBI is responsible for investigating major crimes on most federally recognized tribal reservations. And, they're often under-resourced. And also sometimes reluctant to do it because they feel like maybe a lot of people in the community won't really talk to them because they're suspicious of them, which they have good reason to be suspicious of them. And yet, by absence of full investigative capacity for some of these things, we end up with, a lot of what's been drawn attention to lately, missing and murdered Indigenous persons, or originally it was missing and murdered Indigenous women, because, women were vulnerable to being trafficked or to actually being murdered, but no investigation, and they're just missing and no one is investigating. And so there are these complicated relationships that in some ways maintain our status in structural fashion, despite what seems like a fairly obvious way forward to just a better existence and a little more just response by the surrounding nations.
I wonder, Scott, if I could ask one other question of
Absolutely.
Of Joe Gunn, because I don't want to leave things in what sounds like a downer. I think that in bringing care to the idea of even this presentation, which is a strong part of our department, let's go up and look at a more hopeful ending. Joe, how do you see, in the meantime, until these large-scale problems are resolved, how do you see resurgent care in Native American communities as responding to historical trauma and structural violence?
Yeah, I think the most promising thing is the fact that tribal nations in the United States are able to contract or compact with the federal government to administer our own services with federal dollars. This has been possible since the 1970s and then was amplified beyond just program by program to entire swaths of federal programming, around 2000, a little before 2000, I think. And what that means is that tribal governments are increasingly able to autonomously take charge of services on behalf, including healthcare, health systems, hospitals, and so on. And that gives some latitude in a way that I don't think is possible in almost anywhere else in biomedical care in the United States, for innovation and for tailoring and for accommodating. Now, the challenge is resources, of course, because Indian services are always underfunded and always have been underfunded, but it does allow for kind of an agentic and reflective opportunity to innovate. And so what that means is that some service delivery systems are more likely to partner with traditional healers or with Indian doctors or with sacred and ceremonial leaders to try to coordinate care in a more expansive fashion. I would say for traditionally oriented people, and that's not everybody on a reservation, but it's a big swath of people, you know, health and healthcare are understood to be religious or sacred affairs. And, you know, the first and foremost thing you would do when you're confronting any kind of health crisis is you pray. And you might even sponsor a ceremony of some kind to get health and help and ensure a long life the best that you can with a sincere heart and sacrifices made to the non-human powers who control these things. And so being able to recognize and to respect and to coordinate access to sacred and ceremonial practices as part of healthcare, not necessarily inside the biomedical system, but, you know, in consonant with it, in coordination with it, has been really important and I think helpful. One last thing I'll say is probably the biggest in my lifetime change that I've seen in the Indian country has come with tribal colleges and universities. You know, there must be around 40 of those at this point on different reservations, some in the cities. That's huge because it affords an avenue right there on the reservation for students to come and to learn in community setting, you know, things like, you know, the kind of health, pre-health professions and nursing and, you know, the kinds of preparation that often you do have to transfer away to another institution to finish your BA or something. Not always, but sometimes. And so I think that having institutions under our control that are then able to be really tailored to our people and their experiences and that lift toward greater opportunity and contribution in health is very, very important.
Thank you, Joe. And I know that Kim Sue is now through security, and then oh, there! Wow, we actually get to see you at the airport. And feel free to respond to either Arthur's question or anything else you want to discuss at this point.
Yes, I'd love to. So just building off of what both of you have said. So I guess an interesting example in the convergence of what we do is I'll tell a little bit about the time that I was on the Rosebud Reservation in South Dakota, and really was thinking through some of the programs they had that combined, had local control from the leadership and the people of the reservation, and sort of working on the problem of methamphetamine use disorder and methamphetamine addiction. And it was really heartbreaking, obviously, to hear the historical trauma. One of the people that I got to know, he used methamphetamine quite chaotically, in response to his child who had committed suicide by hanging herself at one of the schools, and so there was so much to unpack there, and the way in which he was using substances and trying to for us to understand why he was using the substances, but also what sources of recovery and healing that were available to him, and they did incorporate a variety of sort of group-based sort of sweat lodges, and a lot of the praying and healing from their particular group, and as well as some sort of Western ideas about treatment. And so I think thinking about the way in which substance use, alcohol included, have been disproportionately, available to, accessed, really overrun by on reservations was really eye-opening to me, and thinking about ways that we can promote and build up programs like that was really important. Even just thinking about taking care of many Black Americans for opioid use disorder, and thinking about their particular attitudes towards substances in their neighborhood, what they've lived through, the mass incarceration of their communities, And there are so many patients who don't want to stay on medication that might be life-saving because of sort of these ways in which discourses around medications, the stigma, the way in which they've been racialized. And so I think it's really critical for us as we move forward in trying to address structural violence and address the structural racism head on to to really have this holistic approach and really to not only have like a biopsychosocial approach, but really to prioritize and really seek to understand structural vulnerability and violence.
Scott, I think if Paul were here, he would really applaud what we've heard, but he would push us to a more radical idea of reparation and redistribution of wealth. And I would like both of our panelists to talk to that point. Let's take redistribution. One of the few redistribution systems we have in America is our disability system. And it's not surprising, therefore, that it's class-oriented, our disability system, with working class people much more commonly on the system than middle class people. Although, of course, working class people are also at higher risk for physical injury. But I wonder if we could get Joe and Kim to talk about redistribution of a more substantial kind that could aid communities. If in fact the problem is in communities that have been broken historically and have been, and of which wealth has been taken away through various mechanisms, one of which is through mining, through removal of property, through the absence of jobs, et cetera, which is an active role of injury, then in fact we should really think about redistribution. And I'd like to hear what our panelists have to say about it. And actually, Scott, I'd like to, since you're a historian, I'd like you to tell us a little about historically, where does redistribution sit in social policies aimed at helping health?
Sure, and that is so nation specific, and certainly in this country, it's been relatively limited, right? I mean, it was even originally relatively kept out of Social Security, but I mean, Social Security itself during the New Deal was somewhat redistributive. Certainly, including medicine within that was certainly fought at the time, and that took until the 1960s and the Great Society initiatives of that decade to extend things further than that. But we've sort of been stuck at that level, right? Through some somewhat progressive taxation schemes, certainly through healthcare, certainly through disability, and certainly through retirement and Social Security. But it's been contested to this time. So it's been, I mean, certainly, I want to say we're far more limited in this country than in many other nations. Arthur, is that your sense as well?
Yes, I mean, I agree with that, but I'm Joe, what about redistribution on reservations and for urban Indians?
Yeah, it's interesting because I wonder if redistribution is really the right language for it, because there is a sense in which I think Native people certainly feel and have a consciousness about so much has been taken from us that really it's the kind of redistribution in order is actually just return of what was originally ours. And so this plays out in terms of this long history of dispossession, with so much of our land that we reserved by treaty. So in many instances, treaties, of course, surrendered land, but they also earmarked or reserved, hence reservation, lands that were to be ours forever. And yet at some point, the federal government discontinued treaty making and started doing unilateral taking of our lands, appropriating it for various reasons and purposes that led to a further dispossession. And so return of land it is a form of redistribution, I'm sure, but it's one that, is sort of like if you steal something from someone and you're forced to return it, maybe we would call that justice more so than just redistribution. You mentioned mining. This is very important. I talked about my reservation in north central Montana, the Fort Belknap Reservation. The Little Rocky Mountains is a mountain range that is the southern boundary of our reservation. And there was a little trapezoidal strip about 5 miles wide and maybe 3 miles deep up there that people discovered gold in, white prospectors discovered gold in the 1890s. And it was our reservation by treaty, and they were crossing into our reservation lands to steal that gold. And the federal government's obligation and responsibility was very clear. They were supposed to repel those miners and protect our lands on our behalf, and they did not do that. Instead, they sent George Bird Grinnell and a couple of other treaty negotiators to Fort Belknap in 1895 to basically wrangle a cession of that little trapezoid of land that was full of gold away from us. And they were able to pit tribes against each other. There was 2 tribes on our reservation, pit our tribes against each other and get enough signatures to basically take that little trapezoid of land. And in the century since, over $100 million of gold have been extracted from corporations of various kinds using all kinds of different technologies. The most recent in the 1990s was an experimental technology that dumped cyanide and leached cyanide through tons of earth that we piled up on filtering materials to try to contain the cyanide, but no, it didn't contain the cyanide. Instead, it ran down the mountains into our water stream and poisoned our reservation water supply in a way that my late father, Joseph William Azure, actually took a stance against, organized kind of a grassroots effort to put a stop to this mining and fought for 8 years of his life during the 1990s to kick this mine out, shut it down, and so on. And, you know, there's lots of instances where mining and other kinds of destructive extractive industry happens adjacent to Indian country or in Indian country, where people can't put a stop to it, even they're aware of it and want to do it. But this is one of those success stories where, in part on his efforts, and a lot of other people who got on board and who were, you know, important to acknowledge as well, the mine had to shut down because after enough violations and penalties and so on that my dad helped to make clear, was able to, you know, no longer profitably extract those minerals. But there's still gold up there, and I'm sure they'll come up with another technology at some point to continue on again. And so that was our land that was wrangled away from us, 100 million in gold taken from it. Now, what would we have done with it? Would we have mined gold? I don't know. We never had the chance to decide that. And so that's an example where you know, I think that's a good moral case for redistribution, you might say. But I think that Indian people, when we look at the lands that have been taken from us illegally and unjustly, tend to think that we should be the largest landlords in the country, that we should have massive amount of rents coming in. We should be wealthy as heck. And yet here we are barely scratching by in too many instances.
Thank you, Joe, for that. Kim, are you still with us?
Yes, I am. I'm en route to the gate.
What would be the equivalent in New Haven of this? I mean, New Haven seems to be a town where that small school and what's the name of it? Yale seems over the centuries not to have contributed a hell of a lot to the development of the town. Is there a case to be made for kind of reparations from Yale to New Haven?
Yeah, I mean, I think you know, there's a very compelling new book called "In the Shadow of the Ivory Tower," I think, by Davari and Baldwin, about the role of, you know, Yale was in the one of the case studies in that book. NYU is a case study in that book. Ways in which universities do not do their fair share for their local towns that are facing significant social issues and actually have siphoned, you know, money away from the local people and have not really paid their proportionate share. So I think that you know, there's some very, you know, the local people in New Haven have you know, campaigns, and a lot of the fellows are joining these campaigns for housing, for Yale to pay their fair share. I think you know, it's really interesting when you talk to, as I moved to New Haven and I talked to different neighborhoods about, you know, high rates of overdose, about substance use, about problems. And it's one of very many things that communities care about, right? And so if communities had the money, they want, you know, the sidewalks to be repaired so that their wheelchairs can get to their hospital. You know, they want to not live in a food desert, you know, that you walk around and there's, you know, 1 or 2, you know, fast food places. They want, they want clean air, they want green spaces. I think listening to and working with communities, it's who have been, historically, that have suffered from, what William Julius Wilson calls concentrated disadvantage. It's interesting because it's like my goal is to have healthy communities, prevent substance use disorders, and treat it. And many times people don't want to talk about it. So I think trying to understand that, I've argued that we need, in this country, we need truth and reconciliation type committees about cocaine, in the ways in which communities have been historically harmed, and still have those memories, and those memories are fresh. The ways in which there's very complicated internalized stigma, and the ways that plays out in achieving health equity. Some of Jonathan Metzl's work on dying of whiteness is very interesting in that regard, like the ways in which people do not necessarily advocate or act in their own health interest for their group. Like white men, for example, would be advocating for policies for increased access to guns when they're the most likely to, their demographic is dying from that increased access to that gun access. So I think, it's complicated. I think direct money should, I think money, I think power, decision making, there's so much complexity, but I'm really glad that, and I think Paul would be glad and has pushed us to have these conversations where it's not radical to talk about reparations, and what does that look like for communities?
And it is striking historically how this has entered medical discourse, right? It's become somewhat medicalized. I mean, certainly this would, if you looked in New England Journal of Medicine for the last 200 years, this would not have been included there throughout 97% of that history. And certainly the medical profession, if anything, was far more conservative, as we know, throughout the 20th century, and shaped a lot of that conservative discourse. And you see folks like Gene Richardson and Paul himself, looking at reparations during COVID, and what reparations had taken place many years previously, that the actual transmission rates of COVID would have been different for everyone. And you actually see an institution like the AMA actively deliberating on reparations this past summer. And so it's a striking moment, and we'll see what the impact that that kind of deliberation will have on more national discourse.
There is a question in the question things. Do you see it?
Sure. This is mostly for Kim. This is how do we hope for and actualize policy or practice change in our communities when so many of our leaders still utilize an anti-harm reduction approach that negates the realities, complexities of substance use, and continues to punish people with usage disorders as morally flawed individuals who need to be controlled by punitive treatment models that withhold support in favor of surveillance?
Well, that's a hard question. That's a really good question. That I spend so much of my time on that very issue, and I continue to iterate on that. I think we're actually in a very interesting time where the federal government has been signaling harm reduction explicitly for the first time, and some of the hopes of doing that are to the federal government to help influence the states, to push the states, and the states are quite disparate in their philosophy toward harm reduction. In Texas, when I give a talk in Texas, everything is prohibited, everything is illegal. And when I give a talk in Connecticut, it's better, but for example, fentanyl test strips are still considered paraphernalia. So again, and this is where I think the use of ethnography in policy is really important, and I'd love for the others to weigh in on this. But really, when you talk to people about their lived experience, when you bring people with lived experience to the table, when you can demonstrate, sort of the ways in which our approaches that people do get better, is really impactful. And so I think, thinking back to when I was in Arthur's class about ethnography and the uses of ethnography, it's in many ways, I always try to bring in people's experiences, people's stories, my experiences, my stories, because data at times, quantitative data at times does not capture and does not speak to what really changes hearts and minds. So I always try to incorporate a variety of data, including the data from the social sciences and from historians to make that argument. And it has been, I think it has been compelling. I think it's maybe slowly nudged the needle. Of course, there's so much to go, and this is my Sisyphean boulder, and we can talk about it more in 5 years.
Great.
If I could just add on to that briefly, that in addition to the alternative to harm reduction that's been described by the questioner, I think in Indian country, what happened is that we very much embraced Alcoholics Anonymous and the 12 steps discourse, starting in the 60s and 70s, so much so that it's really pervasive. When we operate our own treatment programs, it's often based on, the Hazelden model of residential treatment, where AA and working the steps of AA is part and parcel of the approach. And of course, that often is seen to be incompatible with harm reduction because of the recognition, the disease model of, say, alcoholism or other substance use, and the ways in which it's construed as, even in opioid use disorder, methadone, it can't possibly be an answer, many communities would say, because you can't substitute one addiction for another. So there is this kind of hard line resistance in some of our communities to harm reduction, which doesn't recognize complete abstinence. And so, we're trying to make inroads on that front, because I think there's a lot to be said for harm reduction in terms of saving lives and making lives better in our communities, but it has been an uphill fight in many instances. And I should just add quickly, the reason why AA probably has such the hold it has is because it's a spiritual approach. And as I said, health and mental health and well-being are understood to be sacred endeavors. And so having a higher power, being part and parcel of treatment, is really appealing and important for so many Native people.
Arthur, do you have any other questions?
No, I think that in honor of Paul, and this being the last of our seminars relating to the 150th anniversary of the department, and recognizing that even before Paul, the department had a strong engagement, not just with prevention and with social policy, but also with care. The final issue I'd raise is what is the role for care in all of this? And I think it really pushes us toward something that our department should be in the future, hopefully will be a leader in, which is delineating the scope and activities of social care. What does a social care approach to the kinds of issues we've talked about require? What would be the defining operationalized concepts that would lead to interventions that would be useful? So we've talked about the large-scale policies, and those are obviously in future and hopefully can be worked toward. But what are the intervention steps that relate to social care? Now, one thing you see developing in some urban settings, for example, is clinics doing voter registration, with the idea that strengthening democracy and making sure that people are registered to vote as an action of empowerment gives communities greater opportunity in terms of accessing resources and fighting back against extraction, et cetera. I think that social care should be something that this department is leading the way in. And I'd be interested in your view, Scott, and those of Joe and Kim on how the department could play a role in social care.
Yeah, and historically, there have been times where it has tried to do this, right? Certainly in the late 60s and early 70s, it was thinking about how the department should relate to hospitals, to community health centers, and the empowerment of communities. So it's been a thread, at least for the past half century, that has been there. But you're right, Arthur. I mean, to clearly articulated as its direct role in empowering communities. It could be a more formally prominent aspect of the department's overall goals. So it has been there to some extent, but certainly, you've shown us the degree to which care, especially outside of the hospital, within the home, and how that can be empowered, should be within the domain of the department as well. Joe, do you want to relate this to your own work?
Sure. I think of both two different settings, a reservation clinic setting and an urban Indian health program setting. And the first setting is on reservations where we operate clinics. We're always trying to attract providers to come in, and it's always, turnover in providers, and having the fully qualified providers and filling all the provider spots is an endless challenge. One thing that happens is we often are able to offer, the Indian Health Service offers loan repayment to providers who will come stay and help us for a few years at a time. And that helps to attract people to come. What happens sometimes is our providers are too distant or too detached from our own communities because they're not expecting to be there all that long, a few years, and then they leave. I think a main thing that would be helpful would be for those providers to have an orientation program that starts a little before they start to see patients in such regular fashion, to spend some time getting to know our community a little bit, to come out to community events, to visit the different villages or population centers on the reservation, to visit the tribal colleges, et cetera, just to get a sense of showing their face, meeting some people, and having a sense of the rhythms of community life that too often, they're not able to access because, they come in to do clinical hours and there's more demand than there is supply, and they never have time or never get around to doing that really important community interface that would matter a lot for the kind of empathy and connection that would make them better at delivering care that lets the Indian patients know that they are in fact being cared for. So on the reservation setting, that's one suggestion I have. And, urban Indian health programs are really kind of remarkable. There are about 40 of these. They're funded also in part by the IHS. Usually there's not enough money by the IHS to really fund all of them. They cobble together resources from other places. But obviously they deliver clinical care, whether it's, regular general practitioner kinds of care and mental health services care, but they do so much more. They are sites of cultural and community organization and celebration. They offer youth group programming. For example, the American Indian Health and Family Services Incorporated, the urban Indian health clinic I worked with in Detroit for a number of years, they do so very much. They offer sweat lodge ceremonies for anyone who wants to participate. They have drum circles or drum groups. They have youth group participation for young people from the community. They sponsor feasts and powwows. And there's always new programs coming online as different ones phase out. They bring traditional healers to come in sometimes to visit and work with people or talk with people. So it's already a very expansive view of what community health should look like. And it's very impressive in that respect, given that they're able to spin gold from straw relative to the resources that they're allocated to do these things.
And Kim, do you have thoughts on this in your minutes before going on the plane?
I do, yes. I think from my social care and from my perspective, social care and what we, what we could do, how we could innovate. I think as I tussled with this in my book, which is like so many people, and as I moved to New York City, I started working at Rikers Island. So many people said, there was a multiple year debate and advocacy aim to close Rikers Island, and it was agreed upon by 2027 that they were going to close the facility, and they were going to start these sort of new other jails in the other outer boroughs. Now, when we talked about closing Rikers, one of the advocates for substance use treatment was like, this is where, Rikers starts 500 people a day on methadone, and that is because of the criminalization of substance use and possession. And so the social care model would involve, can I set up a one-stop shop? In New York State, they're called drug user health hubs, for example, that we could all do this without people having to go to prison and jail, without having the mark of a criminal record, without having felony convictions, without being on a registry that says that they can't, work for the next X number of years, that prohibits them from accessing public housing or benefits, right? The mark of a criminal record is massive, and it is structurally racist. So a social care model would involve, how can we do this comprehensively and take care of people, within the models, within their communities. I would love if, some donor would be able to let me do that and could give me the money so we could just, innovate and show that, send people who get charged with possession to me, send, what we could do to innovate that kind of place within people's communities would be incredible, and I think it would also reap, tremendous dividends, not only financially, but really morally, and it's not that novel, and it's not that expensive, right? It just takes a tweak of our vision and and our ability to envision a new kind of care.
Thank you. Yeah. Arthur, let me give you somewhat a final word, and just to get your sense over the past 45, 50 years in this department about this, how notions of social suffering and structural violence have evolved over this half century, and moving forward, where you see the department going in their understanding and implementation.
Well, I think this display on the panel was just wonderful in terms of showing where we have come from. And it's one thing to talk about social policy and its interaction with health, and it's another thing to be focused on the details of structural violence and how to respond to it, that we've heard in Boston, in New Haven, in New York, and on the Indian reservation today. And so looking ahead, I wish we had on the program Vikram Patel, because I think Vikram's work with community health workers and providing psychotherapy as a kind of social care is very important. And since he started in Africa and in India, but has been now asked to address community problems in states in the United States, I think Vikram would be a marvelous person to have speak to the social care and the mental health field for the future. And the other part of this is that besides looking at social care as a way of addressing individuals' problems, I think our discussion today also raised the issue of social care as an approach to community problems. And supposing that a care model were not limited to the health domain, but in the criminal justice system, that was the part of what criminal justice was about care, restoring care, providing care, taking care in the way that people are handled. Supposing that was also part of the way that housing was configured or jobs were configured in terms of the way that they contribute to the care of those most vulnerable and to the communities that have been broken by our own past actions or current actions. So I think there's an awful lot ahead on the social care side that this department should be addressing. And it's been a privilege to think through and hear these wonderful presentations, which have shown us where we are today, where we come from, and now we should be thinking about where we're headed.
Thank you, Arthur. And likewise, I'm extremely grateful to all our speakers today and to you. And Paul really, of course, modeled for all of us how to link individual stories with deeper historical analysis, with actual policy change and care. And just privileged to be amongst all of you as everyone continues to carry out that mission. So I want to really thank all of you. Thanks to our audience for attending today. And we'll move forward together from here. Thank you.
Thank you, Scott. Bye-bye.